So a lot of the stuff that we talked about earlier about like kidney function, liver function, and how that influences how long drugs stay in your system or metabolites stay in your system. This also pertains to geriatric pharmacology, because as we get older, our bodies start to break down. And something that's really important in the geriatric community is drug compliance. So what is drug compliance? It is taking your drugs on time and the right amount, right? And it's not just like geriatric people that have trouble with this, but they do tend to have more issues with this than other people. People who have ADHD, part of that diagnosis is not being able to concentrate on certain facts, like maybe taking your ADHD medicine. I saw a meme the other day where the guy was like, real irony is being a parent with ADHD and a kid with ADHD and reminding your kid to take their ADHD meds but forgetting your own. It happens. And something that also makes drug compliance harder for the geriatric community is they're on polypharmacy. It's not like they just have one drug to take. They have a bunch of drugs to take. And some of those are at breakfast, and some of those are at lunch, and some of those are at dinner. And you have it all across the week. Maybe you take this one 3 days a week. Maybe you take this one every day. Maybe you take this one just once a week. Like, so many drugs. It's hard to keep track of it. And so it influences the compliance. I say for the geriatric, typically as we get older, we get more and more drugs to keep us working properly. As a 20-year-old, you might not be experiencing polypharmacy. Or at least not constantly. Maybe you're like, yeah, I have this one thing for my allergies that I take every day. And then you get sick. And it's like, okay, so I have this thing that I take every day for my allergies, and I have this other thing that I take for this bacterial infection. So now I'm on an antibiotic and an anti-allergy, antihistamine medicine. And so now you're in polypharmacy. Anytime you're taking more than one drug at a time, it is polypharm. So again, with those geriatric issues, decreased blood flow with decreased cardiac output influences where these drugs are going to be able to go, how fast they're going to get there, how fast they're going to get absorbed. So with lower blood flow to the intestines, things get absorbed lower. We see that the peak is not really that different. So like they're more of a slow burn. So like it's going to get there. It's going to take a while. And then it's also going to take a while to get out of there, because lower blood flow also decreased liver metabolism, decreased kidney excretion. Another thing is the elderly changes in lean mass and water. So as you get older, you lose a lot of that lean mass and it gets replaced with fat. And so you might weigh the same, but you have 2 times as much fat because you lost that lean mass. And typically older people have less water in their body. Their body's just more dehydrated just at that state. And so if you give somebody 1 milligram of a drug and they're a young person, that 1 milligram is going to be less acting on them than it would be an elderly person. So that drug would be more concentrated. It's like filling up a beaker this full and putting 1 tablet in there, and filling a beaker up this full and putting a tablet in there. So there's less water in this one, and so the concentration is going to be more. Also, the fat distribution changes as you age. Your plasma protein concentrations change as you age. The clearance of your drugs change as you age. The amount of free drug you have floating in your body changes as you age. The amount of free drug is correlated with the plasma protein concentrations and clearance, of course, with your kidneys and liver function. And so as you age, all of this stuff changes. Where those drugs go can also depend on your fat distribution. So those pharmacokinetics, like where is the drug going, how is it getting there, how long is it going to be there, all that is influenced with age. So you get decreases in the DMMS, so these drug microsomal metabolizing enzymes, especially in your mixed function oxidase systems that break down like benzodiazepines, like Valium. A lot of that gets broken down in first pass by the liver. The liver's not working well. If you didn't know that and you gave them a dose of Valium that was for somebody with a healthy liver, you could OD them on Valium because it's not getting broken down in first pass like it typically would before it reaches systemic circulation. And that is it for our first lesson in pharmacology.